I'm Julia.
And I'm Michelle.
And we're just getting better. This is a podcast for women just like us who are navigating life and just getting better.
Hey, Julia.
Hey, Michelle, how are you?
I'm doing great. I have fireworks going off in my life right now.
I know. I was like, what just happened? I just felt like...
I am on fire.
Yeah, good. I'm not. I am on fire, but not the same.
You have an internal heat going.
Having a personal summer.
A personal summer. Oh, I'll tell you what happened to me recently? I'm kid you not. So I did not make this up to talk about our guest today. This is a true life experience that happened to me in the past 2 weeks. 54 weeks. I have been without having a period. 54 weeks. And 2 weeks ago, bam, out of nowhere, had another period.
I don't miss those days at all.
You know, I had mixed feelings about it. I am on, I know it's not hormone replacement therapy. We could talk about that. I am on menopause hormone therapy.
Okay.
And so I have a little bit of estrogen patch, little daily pill of progesterone at night, and a little bit, like 2 milligrams of testosterone tablet that dissolves under my tongue every morning to keep me from killing everyone. And so I felt like, once I started like having this, like, what is this, this old friend who I thought had left me. And I didn't feel so bad about it. I kind of felt like all of a sudden I realized that the fatigue I'd been experiencing and the brain fog that had gotten worse, well, maybe it was because of that. And then also I was like, so my body is still producing some estrogen, and about that, I kind of felt okay.
Okay, well, I had a
miss this. There's a normalcy to this that my life.
No, I don't miss it. I had a hysterectomy at 42. I was very happy to get rid of everything associated with that. I always, all my life, I was one of those people, like, I started very early. I started at 9. A lot of information.
Oh, shit.
Yeah, so, but
wow.
I knew a lot about everything that was happening because my grandmother was a midwife, so I was very conscientious of things like that, and my mom tried to make it like, oh, you can stay home and then we'll have a day out. She was trying to be one of those moms, which I understand because that's very early.
Yeah.
But baby, I was bye. I just did a party.
Like,
I did a dance. I was like, get out. I am so happy. Like, yeah, I don't miss it. When some of my friends, I'm like, yeah.
I wouldn't say I miss it. I don't miss it. But when it came, I was like, I'm okay with this. Now, the problem was I was getting on an airplane and, of course, so it's not going to come when I'm like in town for weeks on end. But, I dealt with it. It was like 3 days. And it was like 3 days of like, I have to wear a tampon and I have to change it regularly. So I was like, I don't know. I have mixed
I just
feelings
miss that. I don't have to go down that aisle anymore at the store. Yeah. It is just an aisle. I can just bypass and go, hey girl, bye. Been there.
Well, I did have to buy some at the airport because I only had 2. Because I haven't, like I said, it had been over a year. So I thought maybe, but no.
You were in the home stretch. Okay.
Yeah. But I mean, honestly, could my body have planned this? I think my body was preparing as my mind was preparing
for this interview.
Amazing guest today. Yes.
Well, with that being said, we can bring on our amazing guest because I know we have a lot to talk about in such a short amount of time. So I am going to read Dr. Kamilia Smith's bio because it is amazing. And I told you earlier that even though I don't live in Dallas, I'm thinking about making her my doctor. I'm thinking about like, I could come down like for work, to see you and we record and everything like that. So I figured I might as well make her my doctor because I'm not happy with the one I have in DC. And I'm like, well, why am I doing this? So I might as well.
Yeah, you may as well.
Might as well. So let's get started. Okay. Dr. Kamilia Smith is the founder and director of Charleston House Gynecology. She is a board certified in obstetrics and gynecology. She is also a certified menopausal practitioner through the North American Menopause Society and a clinical assistant professor. Dr. Smith has completed an executive healthcare leadership fellowship from Creighton University and pursued additional training in obesity, weight management, and aesthetics to address the many needs of today's women. Dr. Smith believes in the advocacy for better health care for all women. Welcome, Dr. Kamilia Smith. It is a pleasure having you with us today.
Thank you.
I have a quick question that I just now thought about before we start. The fact that I know women who are going to listen to this, most of them don't know that there's a menopause society. Because like that, can you talk about that just a little bit before we get into questions?
Yeah, and I think that's a great intro because neither did I. I'd been practicing obstetrics for 15, 16 years. And when I decided to step outside of my traditional practice and figure out what the next phase was going to look like for the patients that I were caring for, I discovered the Menopause Society. It was the North American Menopausal Society when I received my practitioner certification. Now the new name is Menopause Society, but regardless, it remains the same. It remains sort of the flagship, the gold standard of what we draw our recommendations on for women who are evolving into the menopausal transition, postmenopausal. And they cover, I mean, it is the experts in cardiovascular disease, breast cancer risk reduction, cognitive decline. So it's not just hormones. I mean, hormones is everything basically that you'll soon become familiar with, I hope. And so the Menopause Society really touches on all of it's a very multidisciplinary systemic approach that involves mental health, of how we really support women and increase their lifespan, increase their quality of life as they age as well.
Wow. Excellent. Wow. Well, let's just jump right into it then, since we've already been talking about menopause. We'll just get straight into the deep end here. So, after centuries of women living in a menopause desert, accurate information is finally being talked about, as you just shared. And so, we are still kind of fumbling around in the dark. It's amazing to me how much we as women don't know and don't understand. And perhaps to some degree, it's because the information hasn't been out there and our practitioners haven't been talking to us about it. So there's so many questions when it comes to menopause, perimenopause, how to know when it started, what are the symptoms, how long will it last, what's the difference between perimenopause and menopause, what happens after menopause, all these different questions that we could talk about all day. So for the sake of time, what are the must-knows when it comes to this stage of a woman's journey?
Well, no, I mean, it is exciting that we're finally talking about it. And I think for so long it was too little information and it was the wrong information. And now we're moving to a time where it's a lot of information and we still have to make sure it's the right information. And I love that women are getting access to things about their own body and how to advocate on behalf of themselves. And so I think it's great. I just, when I very first started out, like I said, when I left my practice and left obstetrics behind, people thought I was practicing some woo-woo medicine. And frankly, I had to teach myself and then subsequently my patients. And what was interesting is women were miserable and frankly accepted it as the norm because they knew that I couldn't help them. They weren't seeking answers in the medical field. And it was sort of like the blind leading the blind. And I always say when I started Charleston House, when I think about the pillars of women's health and what women should be offered as they're aging, I didn't really know. It was driven by the woman that was sitting in front of me, literally. She pushed me to pursue my knowledge based on what she came in with and what she needed. And that's really how it's gone over the last 5 years. And so it's, as a physician, I am a lifelong learner. And I always tell people when they talk about going to med school and going into medicine, I'm like, you've got to be a lifelong learner. I mean, it really is. And menopausal medicine couldn't be any more relevant in that aspect because we are just beginning to see it explode and become center stage. And so I think, to your question too, it's like women want to know, where am I in menopause, right? So they want to know, where am I? And I always say it's not like, amusement park, although you feel like you're probably in a funny house. It's not an amusement park and there's not a map that says you are here, right? The body is very dynamic. it is changing rapidly, as is such for a menopausal woman. And so, as you guys well know, I mean, you just had a period out of nowhere. I have a lot of questions about that period, by the way.
Okay.
It's not that straightforward and need to know what we're doing about it. And I've got a lot of questions about that. But
okay.
Women can wax and wane, and they'll come in the office and say, what I can see them one day and I check their labs and look at their clinical symptoms and have a pretty good idea of what I think the next 6 months are going to look like. And then they come back 6 months later and it's night and day from what I thought. And what we have to remember is nobody's going to do menopause exactly like the woman next to them. And a white woman is definitely not going to do it like an African-American or Black woman. We are all going to do it differently. Genetic variability is probably the biggest predictor. When did your mom go through menopause? What was her reason? So for Julia, why did she have that hysterectomy? What was necessitating that hysterectomy and that surgical intervention? And she had surgical menopause. That's not the same as a evolution of menopause from a physiological standpoint. But genetic variability plays into it. Where you live matters. Your access to what you eat, how you get your food, how you move your body, all those things factor into it. And so suffice to say, we're just really learning. So it's no wonder why women are confused. And they always want to know, where am I in menopause? So do you women, do you feel comfortable with the definitions as you've sort of gleaned them in your own little learning about what they are? I'd be interested to know how you guys feel about that. This is menopause, this is perimenopause, this is postmenopausal.
Well, for me, I don't honestly know when like peri transition to menopause. I'm 51. So I just turned 51. And because I had my hysterectomy at 42, but I kept my ovaries because they didn't want me to go immediately into menopause. And it wasn't until just one day I woke up, and I used to have, I call it the photographic memory. And I was like, I can't remember anything right now at this moment. It was just basic, simple. I don't mean the phone and I forget the keys. It was dates that I could not just all of a sudden remember. And then I stopped sleeping. And it was the lack of memory and the stop sleeping was okay, this is bigger than just I can't sleep and everything like that. And then I was fine until 48. I was just sitting at home one day and I felt a hot flash. And I said, oh, nope. We are not doing this. And that's when I was like, okay, I have to see somebody. But, that was the one symptom. And I've been okay. And I was telling Michelle until last night, I hadn't had a hot flash in a few years. And then all of a sudden last night, one just came out of nowhere. I was like, okay, I wasn't eating crazy. I had a smoothie for breakfast. I was just thinking nothing. I didn't have the triggers. I didn't have caffeine, the ones that I know about, right? Yeah. I hadn't had any wine. I hadn't had any alcohol. So I'm just I don't understand. And it was more of a battle for 4 hours of just, should I take a cold shower? Should I get back into bed? Then all of a sudden my freezing. 3 fans are on and then 3 fans are off. Thank God they're remote. So it was just... So I think now that's why I'm saying I need to see the new lab work, because my labs are old, right? And see where I am right now. Right now, my brain is back on and everything like that. And I'm just curious, am I going back into the hot flash phase? Because that's not a fun phase.
Sure. It's Dr. Smith. Our bodies are oh, okay, we're going to talk about this.
Yes.
For sure. Absolutely. Yeah.
And so for me, being a Black woman, I feel I'm often not heard going to the doctor. I feel I spend more time switching to find the right doctor. And sometimes my favorite doctor moved away. And so that was really a reason why I'm just one of the friends was I like my doctor. And I'm just I want to ask more questions of supplements, outside of just the patch and everything in different things, because also my stress level is very different than a white woman, right? Just living in the world. And so I feel the doctor isn't listening. And so I just made the appointment because it was time to make an appointment, right? Mm-hmm. But then now I'm just why did I do that? But I was well, let's just check the physical appointment off, the gynecology appointment off, because it's the list of just getting everything done like I normally do in May.
Well, I mean, I think for you, Julia, I think number one, there's been such a fear around hormones for a long time with the WHI study. So you're battling that, number one. Number two, Black women are frankly scary in medicine because you guys can do crazy things in pregnancy. Y'all can do real crazy things with your blood pressure. Your rates of cardiovascular disease are just so much higher. And so when you think about a high risk woman and you've already got a fear of prescribing hormones, you're probably the last person that's going to get any, right, from a practitioner. And there was a scientific review in 2022. And so the SWAN study is a beautiful, I wouldn't imagine that you guys have heard of the SWAN study, but definitely would make me happier if you have, for that to be common vernacular. But it's a study of women across nations. And what does that mean is we looked at women across all races, and they self-identified with their race. And it's an ongoing longitudinal study that's in its 16th, 17th year maybe. And there was a scientific review of 25 years of data from the SWAN study. And what they realized, so you can take the SWAN study and you can look at anything. You can look at cognitive decline, what is word finding, word processing, memory recall around menopause. So you can look at it for cognitive decline. You can take the SWAN study. You can look at sexual function. And one particular scientific review, they looked at, well, how do Black women really, what is their experience in menopause? And what they found was that women who are Black, they will go through menopause about 8.5 years earlier, right? So the median duration of hot flashes or vasomotor symptoms, VMS, what we refer to it as, is VMS due to menopause. The average woman will experience it for 7.5 years. And you think about an African American or Black woman, she's going to do it a year earlier almost. And her symptoms are going to be much more severe. And that a lot has to do with vasodilation properties. It has to do with a lot of things we just don't understand, right? And so I always go back to that, when I used to really deliver babies, a woman that could get really sick on me really fast was oftentimes a Black woman. And we know they have a higher mortality rate, higher death rate around childbirth. So there are things at play. And so I think if you're dealing with practitioners and a paucity of information and experience in the medical field, and people are scared to give hormones out to even to the safest woman, then for sure they're going to look for reasons not to give it to somebody they don't feel safe prescribing it to. And that is why you have to advocate for yourself, which is okay. I think we grew up in thinking like, well, a doctor's just always going to know best. But if they're not going and getting that knowledge and pursuing it. So if it were me and I was a consumer, which I am a consumer, I have to have a doctor myself. But as a consumer, I want to know what their level of knowledge is, right? Like, how are they pursuing that knowledge? What is their level of understanding? What is their participation? Have they recently looked at the most recent position statements from the Menopause Society? How do they feel about, my risk of cardiovascular disease since I had preeclampsia and pregnancy and putting me on hormones? I mean, we really have to be asking these questions of our provider. And it's great that we have information online. I love that. But be careful, I will say, because a lot of these great, smart physicians are making very big statements online that may not necessarily apply to you. And it is a personal relationship between a practitioner and a woman, whether you're an MD, a PA, or NP. It's that personal relationship, and it's spending time with a woman, understanding what she carries. Like you said, what is on your plate and what does your stress level look like? Just being a Black woman in this world, you have a different level of stress, right? And so we have to understand those nuances of a woman, and we have to understand how she receives information. We have to understand what her bias and fear are around the information that she's receiving, and what is the likelihood that she's going to walk out the door and do what I've just asked her to do because she's got trust in my recommendations. And really, that trust is only built over time. So it's hard for me to think I can jump online. I love that women are getting access to hormones now, but jump online, spend 5 minutes with a provider through a TV, and then they know what's best for my uterus, my breast tissue, my brain, all of those things. So we have to take everything with a very large grain of salt and find the right thing for you. And that is how I would, approach a conversation with a practitioner. And I wouldn't normalize common things, right? I always say, well, like, what man's comfortable walking around with wet pants, with urine in his pants? No man. Like, none. I'm married to one, and I know for sure, like, he needed the stitches out of his back. And I was like, can I do it when I get home today? He's like, no, I got to have it done right now. And I thought, I'll probably walk around for 3 years with stitches in my back because I can't reach them because I don't have time to get anybody to help me. And so women will just carry things around with us. And so, that's also on me. Like, if I say, well, how's your sex life? And they're like, fine. Well, that is my way of saying, I really want to have to talk about it with them. So I'm going to take that fine and keep on going. I will tell you that when I was starting out in my private practice, and I would say, well, what about this atrophic vaginitis or low estrogen in the vaginal tissue? And literally, I kid you not, they were like, don't ask about it. If they don't mention it, you don't need to worry about it. Because nobody wanted to open Pandora's box. And I'm like, that is the gateway to a woman's sexuality. And like, also, which is tied to a lot of things about how she feels about herself, how she feels, her body image, her self-image, her relationship with her partner. But we don't need to ask about it and wait until they mention it. So I think it's on us as a provider, but it's also on the woman to stop pushing things under the rug and normalizing common things that I don't think, our other species would exist with, frankly.
I've never in my entire life had a doctor ask me about my sex life. Never.
Mine always does, and I always say
never. Like,
fine.
no one no one has ever asked me about that.
Mine told me that what did she say? Something to the effect of that an orgasm is like a muscle and you have to use it or you're going to lose it, and you have to have at least one a week, whether you have it with or without, like however you have it, you need to have one at least a week.
I mean, that's okay. I mean, I guess. Well, your trainer could have told you the same thing, right?
Yeah. But that's what's interesting. So, because I saw something that you said on your Instagram page for Charleston House about, because I wear an estrogen patch, and that's the estrogen that I have. And you said something about a cream or a suppository or something actually for the vagina. Can you talk about that? That was fascinating.
I'd love to. Okay. And
we're here for all of this.
Well, there are wonderful people out there who really, they preach this from a very large, very well-established platform. So I love that I'm getting to talk on it, because there are plenty of good people out here who are light years ahead of me. But what I've always said is the vagina loves estrogen. The vagina has loved it since the day it had it, and then when it's gone away. And so it's like anything else. I put serums, I put all kinds of things on my skin here, right? So why wouldn't I treat that tissue? And majority of your estrogen receptors are in two places. They're on your face, and then they're in the genital area. So I mean, why wouldn't we treat it? So systemic estrogen therapy, like what you're on, is not the same, nor does it replace giving a woman local therapy. Local is to the vaginal tissue directly. Now, you can give local therapy through something topical, through a ring, through an insert, through an ointment. I mean, there's lots of ways of giving it. And you can even give local therapy. This may be a little confusing, but you can even give local therapy to a woman by giving her a pill by mouth that targets the vaginal tissue. But we have to give local therapy to the vagina. And the way I want you to think about it is the estrogen has three important roles in vaginal tissue. It's got a support role, so collagen. It's got a role of producing a certain type of pH. You want a very low acidic pH in the vagina. And the way that's done is you have this nice, beautiful layer that binds up estrogen, produces glycogen. Glycogen produces this very nice good bacteria called lactobacilli, and that lactobacilli produces hydrogen peroxide, lactic acid. All those things are at play, and that drives down the pH and keeps bugs out of there. So common symptom, and what we refer to it as genitourinary syndrome of menopause, right? GSM, and it used to be VVA, which was vulvovaginitis or vulvovaginal atrophy, VVA. And so we changed the name, the nomenclature, to give a nod to the fact that there are estrogen receptors on your bladder. But GSM can be it is the great mimicker. Women are like, oh, I have a yeast infection or I have a bladder infection. And while they might also have that going on, it's because they're having symptoms of low estrogen. So it is the great mimicker. But even if they do have infection, you have to think about the pH changes. So when they lose estrogen, that pH rises, you lose that lactobacilli and all these bad bacteria that you find in your bowel, in your gut, that starts to set up in your vagina. It was never intended to be that way. That can ascend into the bladder. I have this one particular patient, and she's like, how long do I need to be on local estrogen therapy? And I'm like, till death do you part. And she doesn't believe me. And she comes off of it, and then she calls with the bladder infection, and she's like, you're right, I got off of it and I've got a bladder. And her biggest symptom is a bladder infection. And so we have to really, again, you got to dive deep and understand what's going on with the woman. But it is safe to say, Michelle, and there's very few things that you can say in medicine that are blanket statements and say them safely. It is safe to say that every vagina really needs estrogen. Now, can every woman be on it? There's very few that can't be. But for the most part, and you will hear rumblings of, well, we don't have good safety data. We've got tons of safety data. It's just the FDA refuses to remove some of the things off of there's a black box warning on it for increased risk for DVT. There's no increased risk that we've really found with breast cancer, endometrial cancer. And so we should be giving that with a lot of confidence that not only will every woman benefit from it, but she also needs it for reasons that maybe are beyond her level of understanding. And so that's one where you can't wait for a woman to report symptoms to you. You've got to ask her about it. And then also you don't want to get behind, because you can have a woman that's like, oh, I've been divorced for 10 years. I haven't been sexually active. All of a sudden she's entering a new relationship. She hasn't been on vaginal estrogen. And if you don't treat her the first time she has sex, her world is going to be on fire. And so when you lose that estrogen and you lose that support, you can get narrowing of the entry to the vagina. You can get you get all that loss of elasticity. And so there can be a lot of a pain associated with it. You can get frequent infections. So there's a lot of reasons why we want to support the vaginal tissue with estrogen.
Wow. This reminds me of the thing. I didn't see this. Julia told me about, was it Halle Berry?
Halle Berry went to the doctor and the doctor told her she had herpes. She didn't.
No, just menopause.
But it can feel that bad. I mean, it can really feel that bad, and it can happen. Now, what I want you to know, just for your own personal use and for anybody listening, is it's not typically right when the menopausal transition happens. It usually is like 1 to 2 years after, but it is a progressive condition. And when I use the word progressive in medicine, that means it's going to continue to progress. So therefore, we have to always continue to treat it, because it's not just going to fix it on itself, right? Fix it on its own. And you'll hear about all these like laser therapies and all these fancy, like, spas have all these fancy expensive machines you can use for the vaginal tissue. Estrogen is the gold standard. There's no question. Now, a lot of outdated information still says, well, let's try moisturizer first. And moisturizer is great. I put moisturizers on my face, but before I put a moisturizer on, what do I do all before that? I put all those peptides and collagen. I put all those other little building elements topically to my face before I put a moisturizer on it, because the moisturizer is that barrier protectant, so it can seal it in. So you still got to bring the structure back to those estrogen receptors.
Fascinating.
Wow.
Fascinating. Yeah. Which you have a very different approach to gynecology with your concierge medicine, in a way that, like I said, I've been through a lot of doctors a long time, especially women doctors. And I feel like a lot of times there is I have a history of heart disease in my family, but they'll go, all your numbers are correct. They're like, they look good, but there's still concern on my end because I know my family history. But through your concierge medicine, how do you tackle the whole woman? Because that is like a thing that I feel like going to so many doctors, I'm getting a piece of a doctor and I'm trying to add the tidbits to make it a whole doctor.
Right. Well, I mean, I think, I don't know that concierge gynecology existed when I started. I wasn't really focused on that. What I was focused on was meeting the needs in the woman in front of me. And so if I was leaving to go deliver a baby and a woman had waited 3 months to see me, I literally left her in the stirrups and I spent 10 minutes with her to talk about all of her comprehensive health care. I was like, well, this isn't, I wasn't meeting anybody's needs. I was feeling super discouraged, and I knew my patients for sure were leaving empty-handed. So that's how it really began for me, was how do I create a comprehensive approach? And what I did was I just started a gynecology practice, but it wasn't 14, 15 months where I told my husband, I was like, I literally put lipstick on a pig. I am now doing more complicated visits in a smaller amount of time than I was before, and spending less time and trying to do comprehensive gynecology in a 15-minute window. And I thought that was the answer, was just to create a gynecology practice that solely just focused on everything outside of obstetrics, but that really didn't work either. And so it was an evolution for me to figure out, how do we make a creative healthcare solution for women that can meet their needs? And I always say, when I started out, it's a latte a day. And I love me some Starbucks. I love all my bucks. I love all my drinks, but it's a latte a day. And I know that not everybody has the resources to spend that money, but I always say, look at what you're spending on. And the women who signed up for Charleston House early on were women who really, of course, had the opportunity to do that, but had the means to do it. So I had some people ask their parents to pay for it. I had some people that asked their employer to pay for it. I mean, people got real creative because they wanted to be able to have access to it. And then it was like, I always say I'm the gynecologist that starts at the top and works her way down. Like, if I don't know what a woman is carrying around, what she's housing, and that can be remote trauma, current daily trauma. I mean, it can be so many things. She's got a child with special needs that she has to drive an hour each way to get them to the right school. Well, I'm asking her to move her body and take a morning walk. Where's she going to do that, right? How's she going to do that when she's living in the car? So you have to know what a woman is dealing with as she comes in. So frankly, then when they first sit down, they're probably wondering what I'm doing, but I'm gathering information. And I think that women need a coach. They need a partner. They need an accountability partner. I know I need that. And I don't know why or how we ever got away from that in medicine. And I wish I had all the answers. And I wish that everybody could have access to the services that we do. It's not the world that we live in, but we have to figure out a way to rethink the model. And we have to meet the needs in front of the person in front of us. And we cannot do that if we were seeing them every 5 to 10 minutes. And that's what the healthcare system is requiring of a practitioner. It's not I will tell you, it is not the doctor's fault. It is not their fault. I will say that over and over. It is not their fault. I would say majority of people that go into medicine do it because they really care deeply for caring for people, and they like to be a healer and lifelong learner. And I know firsthand, my mom had early onset Alzheimer's, diagnosed at age 54. And I saw firsthand when medicine fails and it does not provide you a care, you have to give people hope. And so sometimes I tell patients, listen, I can't make the menopausal transition necessarily painless for you, but I can give you hope. I can hear you. I can listen to you. I can walk beside you. I know when you're 50, you want to feel like you were 40. I do too, but I don't know that I can make that happen. But people, they just really want somebody to walk beside them and advocate on their behalf. And I think that is really what's unique to our approach. And it's not just me, it's everybody that's in this office. We all have to do it collectively. And I think we've gotten away from that in medicine. And so when I created Charleston House, my goal was also to make it a community, I think hospitals have a calling. They have an obligation to support community health. And that's really what I got when I was doing my fellowship at Creighton, was like, well, how can I have an impact on my community? We can hold events. You don't have to be a patient of Charleston House to be a woman of Charleston House. And I say that over and over and over. And sometimes when I invite people to come to an event, they're like, I know, but I can't sign up to be your patient. I'm like, girl, I don't need you to be my patient. I need you to come and learn about your body. And we want to be able to be a place of accountability for reliable information for women. And we do that through various ways and lots of events. And we've been really fortunate to be able to build a network of women that can sit in a room and share experiences about their health. And when we begin to really, like what you guys are doing here, making the conversation really just approachable, right? I don't know why vagina is such a bad word. And we're at least talking about it now. But I think women need to learn from each other in a setting that looks different than, I just walked off the tennis court. Now, if they're learning at that because they're with information I've said, hey, I think you need to read this book. I give my patients a lot of homework, a lot. I give them a lot of things to read, give them access to things so that they can hear things in a different way, that it's not just my voice they're hearing, and they can begin to learn their own voice through that as well.
I just realized, I think there is, for especially high achieving women who are very smart, I think it's almost a shame that you don't know this, right? It's one thing you don't know, and you don't know how to explain it. So a lot of women, I meet women all the time, they never talk about menopause. And I'm watching them literally in front of me start sweating profusely. And I'm start talking about it. And I think they feel ashamed that they don't know what they don't know.
Well, but also think about the world we're living in, right? As a woman, there's this ageism theory, right? As old is bad, right? And so now, and women are like, well, I can't do anything about the fact that literally menopause is like falling off a cliff. And so I can't do anything about it. And I don't want to be seen as old, right? And then you have the anti-aging ageism where it's like, well, don't fight it, accept it, do everything naturally. You should just accept it. Women are balancing these two dialogues going on in the background of their mind. And I've got to figure out which one has the loudest microphone and the one they're listening to. So when they come in, I'm trying to figure out which voice they're hearing, because the world is feeding all of that to them and making it rather confusing, and there's a lot of shame around it, I think, of just saying, well, I don't want to be seen as, I can't tell you how many times I ask my kids, I'm like, do I look that old? And they're like, no, Mom, no, you don't. You look the same as you did when you were 20. And I'm even asking them that, and I know what they're going to say, right? I just took my daughter to Charleston with me, and I was speaking at a derm conference on estrogen in the skin, your face and your vagina. Put a plug in for that. And, I'm walking around with her and I'm realizing there is not a soul in town that's looking at me. They're looking at the 15-year-old next to me. Some of them were older men that I didn't want to be looking at my daughter, but I was like, I'm kind of at that old woman. They can't even, they literally couldn't see me. And it made me realize, we're no longer seen.
Yeah, I feel like that too.
She's being seen by old men, young men, no matter what man it was. And I will say, we'll brag on her. She's beautiful. But I was like I'm kind of invisible. I could probably be walking down the street in King Street in Charleston naked. I don't think anybody would see me because I'm just old and invisible now. And I really felt that. And it was so interesting, but I also felt a lot of power to that because I was like, but I sure have learned a lot in all these years.
Is that where the name Charleston House came from? Did you name it after Charleston?
It is.
I did. Yeah.
Yes, it is. And my daughter's name is Charleston as well.
Oh, great. Oh, yeah. I love Charleston, South Carolina. Yeah.
Yes. Yeah. My husband and I were there for some training in our first year of marriage, and I had this particular experience with this wonderful group out in Mount Pleasant. They probably don't even remember me, but they had created this model, and I was like, wow, they are really thinking about the woman, right? And it probably was just like a smart business move too, but they had a breast surgeon come I don't remember how often he came, but there was a breast surgeon. So I was rotating through their clinic as a 4th-year med student. They had a breast surgeon, they had an acupuncturist doing for hyperemesis of pregnancy. They had a dermatologist can do skin checks because, I mean, how crazy is it when you're like, my doctor felt a breast mass and now I got to wait 3 weeks to get in to do anything about it or get imaging or see somebody. And so they would have people, multi-specialties rotating through so that women would get this comprehensive approach. And I thought, to me, that's what I would like to be able to deliver one day for a woman, is a very comprehensive. I don't want to practice in a silo. I don't want to just practice on these conditions. And I will tell you, we can't practice menopausal medicine like that, right? Like we cannot practice it like a silo, and we're in a silo. And so that's where the name came from, because I saw this very comprehensive approach. Mm-hmm. And I will tell you, when you are menopausal, you'll get, stiff joints, your hips, your shoulders, you get frozen shoulder, and then you get road rage, irritability, anger that comes out of no. You're like, why am I so angry? And so, you think, well, I'll just send you to psychiatry. And no, for your shoulder, I'll just send you to orthopedics. Or maybe you need a rheumatological workup now because you're having all this diffuse joint pain. And then, now you need a sleep specialist. You're not sleeping. And until we see it as this multi-system issue that's going on with a woman, process for a woman, we really do women a disservice by just pushing them around from place to place and understanding that they probably need a multidisciplinary approach, but it usually needs to start with having a talk about hormones and replacing some of the deficiencies that they have.
Oh my gosh. I'm like, I tore my right rotator cuff 2 years into 1.5 to 2 years into menopause. Yeah. Had no understanding of the correlation of that until this moment.
And your doctor probably didn't either. And I don't know that
I don't think he still does.
When I couldn't reach above in my kitchen to get a dish out, I was like, well, that must have been my COVID vaccine,
Yeah.
Way back then. I was like, well, that must be that. I'm like, nope, that was menopause. It is. It's very stiff joints. It's a lot of fun, man.
Yeah. My hips too. That's crazy. I had no idea. Wow. This is just such an insightful conversation. So tell us a bit about Charleston House. Tell us about, so you've talked about kind of the what you created after, but what is it that you offer to women?
So in your initial visit, it's sort of just understanding your medical history up to the day that you step foot in our door. And that includes your obstetrical history, your fertility history. That's very telling for a woman. Her fertility history of infertility and what the cause was is sort of writing on the wall for me about what her ovarian follicular function looks like in the lifespan of her ovaries. So that's really important. Like I mentioned earlier, I'd like to know what happened if you were pregnant, what those pregnancies look like. Did you have gestational diabetes? Did you have cardiovascular disease, pregnancy-induced hypertension? That's super important. Long-term, I want to know about your genetics. I want to know about your family history. We do a lot of screening for hereditary cancer mutations. If you follow the NCCN guidelines to see who should be screened for hereditary cancer mutations, you'll miss 1 in 3 women walking down the street. They won't meet guidelines, but they might actually have a hereditary cancer mutation. We talk a lot about cardiovascular disease, risk reduction for breast cancer, calculate something called a Tyrer-Cuzick score, which is your lifetime risk of breast cancer. We've been calculating that for about 3 or 4 years. We actually do a community event that's centered around that. Women in the community will come in and do an intake, and we'll calculate their TC score for them. And that gives you an idea of what kind of level or interval of screening that they need, whether it's breast MRI or mammogram, and at what interval every 6 months or annually. That is just where we start. And we haven't even gotten to why they're there, their quality of life, right? So mental health, I look at a lot about, I love labs, but nobody loves labs more than a patient, right? Like patients really want blood work. And I always tell young doctors, like, your patient is going to think you're a bad doctor if you don't draw their labs. Draw their labs. Don't go crazy. Don't give them a high $500 lab bill. Let them know what's covered and what's not covered. But a lot of things that we do in women's health is it's a clinical diagnosis, meaning spending time with a woman in front of you and what her symptoms are. And so I don't hang my hat on normal lab values when I've got a woman having hot flashes. And I don't hang my hat on abnormal values when I got a woman who's feeling pretty good, because it doesn't change what I'm going to do in that moment. But things like cholesterol and diabetes, those kind of things do need to be screened, and you do need routine blood work for those. I always tell patients, I'm not going to manage your hypertension. I'm not going to manage your cholesterol. I'm not the person for that. I can tell you if you qualify for a statin drug, but I won't be the one. And so I like my patients that are over 50 to have somebody that we partner with, so that they have another set of eyes on them from a cardiovascular standpoint. But I'm keeping that other entity honest, right? Like, I'm keeping them honest and saying, hey, listen, estrogen's been shown to be cardioprotective. Statins have not. We need to have that conversation with this patient collectively. I do have a lot of BRCA carriers in my clinic, and they have most all have had their ovaries removed by yours truly. And now I'm managing their hormone therapy, and I have worked with their breast surgeon or their breast oncologist to have that understanding of the safety of hormone use in BRCA carriers. So those are sort of some of the initial things we do. And then, it's life is life. Life is messy. So we're always playing whack-a-mole with something, and to feel like they're, I want increasing their quality of life is truly a goal, but so is their longevity. And, I see people saying, well, I'm a longevity doctor. And I would hope that all doctors are longevity doctors, is what I'm going to say.
Okay, you wouldn't think that needs a qualification.
I don't know what I'm doing, right? I'm not trying to. And that is not to discount anybody who's in longevity medicine, but I think every physician should be on the pursuit for knowledge so their patients can live a longer, healthier life, in fact. And women are living longer than they ever have, and the age of menopause has remained stable. So that tells you right there, we're spending longer periods of our life in menopause. And if you're fearful of what your treatment options are, or you don't have a practitioner that you can speak to about it, then the jig is up, right? Like, you're going to have to do something, because you can't bury your head in the sand and think it's going to go away, and it's not. And I think instead of walking down King Street and feeling invisible, I think we can feel pretty good about ourselves. I think there's room for that to happen and to age gracefully.
I think so too. And speaking of aging gracefully, I absolutely adore your style. As a person who wears like big glasses and everything like that, I saw those hot pink glasses on your Instagram, and then you had the sweater that had your own personal embroidery. I can't think of the word right now. Like, do you get I feel like we still in the age where you can't be like fun, sexy, and smart at the same time and be the doctor. Do you get like people coming in and women coming in and they're like, oh, I know they know you're the doctor, but when they see you, because to me, when I look at you, I'm like, she's a doctor, but she's a fashionista at the same time, which I love.
Oh, well,
we see you.
We see you. Yeah.
Well, I don't know. I know in residency, when you graduate out of residency, they always like to say something about you in your senior year. And I was like, most likely to accessorize her scrubs. And I was like, well, there's some things you could say about me, but it would be nice for you to say that I was a fantastic surgeon. So I was kind of like, ew, that's not what I want to be remembered by. So there's give and take in it, right? Like, if that's what people are going to remember me by, and yes, and she was a good surgeon, but I did get a lot of that in residency, I think. And then I see, but then I see the opposite extreme. I see women that are like, okay, I don't need to get half naked on social media to get people to think I'm smart either, and that I'm a good doctor either. So I think there's got to be a nice little balance. But I don't know. I don't think of my style as funky, but everybody always tells me I have a funky style. And so I don't know any different than what I know, which is kind of funny to me, because I'm like, I don't know. I just, like, I am who I am, just like y'all are who you are. Right. Mm-hmm. But I do know that having two daughters keeps me real honest, because they're like, are you wearing that today? And I'm like, yes, I am. And I feel good in it. I'm like, okay, Mom. So,
how old are they?
I have a 15-year-old daughter and I have an 11-year-old daughter. Okay. And then I have a 17-year-old son. We can't forget about him. He's probably had the toughest time. He's grown up around all of this his whole life. And he's like, how long do we have to talk about estrogen or menopause at the
I love it.
Yeah. He knows it all. He knows his way around it. He's just like, yep, I've grown up around it. So I think he's probably paid the highest tax on being in the house. But he'll be great with his wife one day and sensitive to it. And what I will say to that is, I do have patients and have their significant others read a lot of things that I send their way, so that they can appreciate what their wives are going through, or their partner, whoever they're spending their time with. Because I think it's important for us to have that level of empathy with each other. So
Yeah, I've had my husband read things and listen to things and like, you need to learn this. Yeah.
I don't know where it goes, but at least we feel better that they listen. I don't know where it went, stuck, but for sure.
Absolutely. So before you started Charleston House in 2019, how long did you dream and plan and plot it? And what has the past 5 years of running it taught you about yourself?
Well, it's taught me that I am my biggest obstacle, I will say. Most things, just a lot of self-limiting beliefs and a lot of, I would just say things, and I think words have power. So I would say things like, I'm not an entrepreneur. I spoke at the Riveter and I was like, why do they want me to speak? I'm not an entrepreneur. Who says that, right? When you're trying to start a business. I just wanted to practice. I literally wanted to practice good medicine. And I think people are like, oh, sure. I'm like, no, I really did. I did not have a business plan. Let me tell you, doctors are terrible business people. I did not have a business plan. I just knew I wanted to take good care of women. And I knew if I was lean on my overhead and the numbers made sense on the back of a napkin, almost literally, I could practice good medicine. And so I think there is a level of when you are committed to what you're doing and you do it for the right reasons, then the rest will follow. And I do believe that. But there were years and years of tossing and turning on the pillow and waking up in the middle of the night and frantically writing things down and just praying. A lot of prayer. I really just leaned on my faith a lot. I was like, all right, Lord, I don't think you brought me this far and showed me the desires of what I have. I remember I would literally just be standing there thinking, this can't be for me. I feel like this is coming from something and I need to go see what this is about. And so that, really is what I did. And I remember my husband one time said, when you're exhausted and you're doubting yourself, I need you to see the face of the women that you were treating. If that's the reason you get out of bed, I need you to see those women, because I would just come home so discouraged. And people thought that I wasn't practicing medicine anymore. I will say one of the hardest things I learned was that the people who had trained me, because I did something different, I didn't fit the mold. And I frankly didn't think my patients fit the mold either. It was like something was wrong with me and that I didn't want to work anymore. I was not, oh yeah, we didn't think you were going to work forever. And now I'm like, I work more than I ever have now, like trying to keep the doors open and the lights on and meet the needs of women and increase my knowledge and do something that's never been done before. And one of the hardest things really was not having a support system around me in my own field. And so I had to go find it. And I have found the most wonderful humans on the face of the earth in Manhattan, in Michigan, with the very same calling, a same, idealistic idea about how healthcare should be for their patients, that constant pursuit of knowledge, that after hours touch points with women just to make sure they're getting where they need to be, and just driven by a desire to really change healthcare for women. And I found those people. They weren't unfortunately here for me. They weren't in Dallas. They weren't at Baylor. They weren't people I had trained with and worked with for 15, 16 years. And so I really felt a lot of shame around that being different. And if I had listened to that, then none of this would be here. And I don't know what that looks like for other people, but I will tell you, everyone told me this wouldn't work. They said it wouldn't work. And the biggest message was, if it would work, somebody would have already done it. And I would say that cannot be true and false. And I believed it for a while. I really did. But when you have to get more uncomfortable staying, right, than going. I was too uncomfortable to leave. So you're like, well, how long did you dream about it? Well, I was too uncomfortable to do anything about it. But when I got so uncomfortable to stay, that was very short. So I had to go, which is why I didn't have all my ducks in a row, because I had to transition patients' care and lives were in my hands. And I was in the middle of pregnancies with patients. So it's a very delicate thing to sort of evolve through. And I would say, if you're a physician and you're listening to this, I have helped many physicians, because many people have helped me get to where I am. Probably same much for you. And so, but it can be very lonely, it can be very scary, and you can really talk yourself out of everything. And you have to make sure that you're not getting in the way of your own self and your own success.
Wow. I'm glad that you stuck with it.
We're all glad you stuck with it.
Well, thanks. Well, now that everybody's talking about menopause, I'm like, okay, now I'm not a weirdo anymore.
Told ya.
Exactly.
Yeah.
So that's kind of helped.
Dr. Kamilia, our podcast is called Just Getting Better. So we would like to know, how are you just getting better?
Well, that is a nice thing. Nobody's ever really asked me how I'm just getting better. I think I'm learning to be okay with not having to do it all. And I think a lot of us have a pursuit for achieving things for reasons we don't understand, but they're already set in motion as we're well into our adulthood, those patterns. So I am getting better at being okay with, I wouldn't say disappointing myself, but just saying you don't have to do all these things to have that self-worth. If you impact just 2 or 3 women today, if you change the life of just one woman this week, then that will have been worth it. That will be enough. And getting away from this tireless pursuit to just feeling like I have to do it all the time. And I think that allows you to really fully be a little bit more present, if you will. And when we talk about being present, and if you're always living in the future as an entrepreneur and as a businesswoman, you will actually miss the things that you've accomplished. And I think last year I was like, wait, was it Charleston House's birthday? Like I missed her own birthday because I was thinking about what we had to do the next year. Right. Uh-huh. And so I was like, I missed my baby's birthday. I didn't even remember her birthday, that she just turned another year and she's still here going. And so I think you got to be present. And I think I'm getting better because I'm learning that I don't have to do all the things I thought I had to do. Or prove anything to myself, and allows me to be more present and enjoy the things that I've accomplished.
Wow.
That's a great way. Thank you. Thank you so much for coming on our podcast.
Thank you.
Absolutely. I hope that you have not only given some information to women, I'm sure, that are listening, I'm sure that you have, but I hope that you've inspired some physicians in other parts of the country to maybe who are feeling kind of the same things that you're feeling and had been feeling, to jump in and take the leap and make it happen for the sake of all of us. So thank you so much.
Thank you.
We look forward to continuing this conversation in the future.
And I'm waiting on the book. I know there's a book in you somewhere.
Ooh, that sounds like a lot of work. I just told you I was going to do less.
We're big readers.
A lot of work, Julia.
Julia and I both. We love
books and learning. So I'm always like, we're highlighting and talking about what books we're reading. So it might not be, I don't mean anytime soon. I think somewhere down the road, there is a Charleston House book somewhere.
I think so too. And I also think, like one of the many, you've said so much that's really resonated with me and inspired me and gotten me thinking. I mean, I live in Dallas, so I would love to come see you, but I'm like, oh, you give homework and books and stuff. And I'm like,
yeah, you had us at the homework part.
I'm such a junkie. I want to learn. I want to know, So yeah, that sounds great.
Well, those brain exercises are good for you. So keep doing it.
Absolutely. Yes. Absolutely. Well, thank you so much, Dr.
Thank you so much, Dr. Smith.
It's been a wonderful
Thank you, ladies.
Yes, it has. Enlightening.
Whew, that was such a great episode.
When I tell you, I'm just like going down the rabbit hole of things she said, the tidbits, like I didn't have time. I was like, okay, remember it. I was trying to remember little things so I can go on my own rabbit hole, especially that study she mentioned. Definitely want to go back and study. Yes, definitely want to go back and listen to, read it really, because like that's like the first woman doctor to me where she's naming a study that this is actually instead of me like, I know this exists, but like she's telling me where to go to also do some research. So I like that as well.
Yeah. Yeah. Yes. I think that she is a wealth of knowledge and information, and we just barely, put a drop in the bucket. So we will have to talk to her some more. So
Michelle, how are you just getting better this week?
Oh, Julia, I am. I'm just getting better because I'm no longer bleeding. But seriously, I listened to recently a great conversation with a woman who I have admired and listened to for a long time and read, Anne Lamott. Do you know?
Oh, I love Anne Lamott. Yeah.
Bird by Bird. Yes. So much more. And I found it a very wonderful conversation. It was very grounding for me, and it reminded me of things that I already knew. That, how you know things, but life is so busy, and sometimes I forget the things that I know to do to keep me grounded and to keep me still and to connect me and to beauty and nature and humans and kindness and love. And so that's how I'm getting better. Not from listening to that conversation, but just from being reminded to just, give myself love and kindness, give the world love and kindness, and just slow and steady.
Oh, good.
How about you?
I am just getting better. I am going to schedule a midweek like probably Wednesday afternoon reading break.
Oh, tell me about that.
Like, not to like just like 30 minutes, not to like read emails or anything, but just read like a fiction book, because what's happening is I'm only reading at night, and then I'm so exhausted that I'm not enjoying the books, and I'm having like, once again, the concentration issues at night because I'm like, I just want to fall asleep. But I decided every Wednesday I would take like a reading break like a kid. Remember in elementary school you had like reading time, like reading room? Yes. I'm actually going to create my own version of a reading room.
I love that. That's so
especially
great.
For summer. Like there's a like summer books are coming out, and you know the beach reads and those kind of books. And it's not about being on a beach to read them. I was just like, I'm just gonna schedule in my 30 to 45 minutes of just like a reading room time, and not reading for work, not reading to think, but reading to escape.
I haven't done that. And my daughter gave me a book for Christmas that I'm still not finished with. In fact, I think I have it here. I'm almost getting closer and closer to being done. On Beauty by Zadie Smith. And I just have about 50 pages left because I read it on planes. Because when I'm here and reading, we've got so much for the podcast and so much for work. And I've just gotten into this nonfiction thing. And I'm not, now when I'm reading fiction, I'm not enjoying it like I used to. I used to devour it, so I need to be more present.
Well, there's a young writer I follow, and she says that when she's writing a book, she can't really read a lot of fiction because it takes away from her writing. But now, like once she turns her book in, she sets this reading time in the middle of the week. Like she's like, it could be, and I'm not trying to read it anywhere else, but just like read for 30 minutes of a fiction book just to escape. Because if I don't, then I'm back researching, and I'm never not researching and never not working almost in that way. So she's like, I take Wednesday from 3 to 4, and she's like, I just read a fiction book. And she's like, I may not pick it up again until the next week, but I just need it. It's her. She's like, it's my version of coffee breaks, but I'm not having a coffee break. I'm just reading.
You are so smart. I'm constantly learning from you. You inspire me.
But here's the thing. She said you have to put it in your calendar. She's like, don't say you're going to do it.
Yeah, no.
So I actually went. I went and made it a calendar date. I was like, awesome. Okay. Yeah. So that's how I'm getting better this week.
Don't reach out to Julie on Wednesdays between 3 to 4.
Nope. So what are we toasting with this week? What are we toasting with? I'm excited.
Tell me, what do you have?
I am toasting with Pine Ridge Chenin Viognier from California. This is the 2023. It's made by an amazing woman named Colleen. I just think what she does, this wine is consistently consistent. It's easy to drink. It's crushable. And it's just a lot of fun. And Colleen is just an exciting, dynamic winemaker. And she's been making this wine for a very long time. And it's one of my go-to whites that I like to refer to people. People ask me all the time with like whites. Easy. Also, you can find it, right?
Yeah, so very easily.
That's what I'm cheersing to this week.
Great price point. Great price point. Yeah. Oh, cheers to that. That is a great wine. Well, I'm doing something a little different. I am doing Domaine Carneros, many know as a great sparkling house, but they also make still wines. The winemaker for their estate Pinot Noir is TJ Evans, and so he made this wine. This is a 2016 estate Pinot Noir. And in 2020, the amazing Remy Cohen took over as CEO for the legendary Eileen Crane at Domaine Carneros. So it is a winery that has always been led by women, strong women, powerful women, and Remy has just continued that, and she's just
their legacy. Yeah,
amazing, incredible woman. She used to be. I met her when she was at Cliff Letty. And she's been at Carneros, like I said, for 4 years now, and she's just incredible. So, cheers!
Cheers to you, my friend.
Cheers to you too, my friend. Another
just getting better
episode. Just getting better. We're trying.
Every day. That's all I got is every day we're trying.
And cheers to our audience and our listeners, and thank you to all of you. And we will see you again next time.
See you next time. All right.
Yeah. Bye. Thanks for listening to Just Getting Better with your hosts, Michelle Williams
and Julia Coney.
We hope you enjoyed our deep dive into some important topics impacting women today. To ensure you never miss an episode, click follow or subscribe.
Head over to isjustgettingbetter.com to sign up for our email list, as well as check out all the links and resources in the show notes. And be sure to follow us on social media. If you love the show, will you please help us build our community by sharing it with friends? Until next time,
keep just getting better.